Hello and welcome to EAO's YouTube channel for this very first Just Ask of 2023. My name is Hayley Edmonds, I'm a journalist, and I'm delighted to be hosting this interactive virtual appointment connecting professionals from all around the world for a live chat with leading experts in implant dentistry. And today is no exception. We have respected professional periodontist and implantologist, Dr. Ramón Gómez Meda, who is with us live today. We're obviously honored to have you. So how are you?
Fine. Thank you, Hayley. Thank you for being here. It's a pleasure to share this time with you.
Good to hear. So Just Ask is, of course, a fantastic opportunity to ask your questions to, of course, the leading experts in the industry. But just before we get started, just tell us where you're connecting from today. I can see we already have people. Aunt is connected from Germany, Per from Norway, Christina from Estonia, Brundila from Albania, Erez from Israel. Is of course great to see everyone connected on this interactive international monthly Just Ask session. So, and we really of course encourage everyone to participate and of course ask your questions throughout this live session. So just a quick introduction to our guest today. Dr. Gómez Meda lectures extensively around the world, focusing, of course, on periodontics, implantology, and aesthetic multidisciplinary treatments. So please don't hesitate in asking your questions for him. Now, today's session is on immediate loading and simultaneous hard and socket tissue reconstruction, immediate implants in class 3 sockets. So that's enough for me. That's a hell of an introduction. Maybe you can give just a brief overview as to the topic and what you'll be addressing today.
Yeah. Well, first of all, thank you for the invitation. I want to thank the EAO and my friend Alberto Salgado for the kind invitation to lecture for all of you. And I want to thank every attendee from all over the world. And some of them friends of mine. And I want to lecture about something that I've been lecturing throughout all around the world for some time, and is placing implants, not only in class 1 sockets, in those sockets with pristine bone, where the cortical bone plate is preserved, but in those cases, more challenging cases where sometimes the cortical bone plate is damaged or completely gone, and not only that, sometimes we face cases where we don't even have enough soft tissue. As you can see on the left side of the screen, those cases with a gingival recession. And in the past, we've been told that in these cases, it's much more predictable to go for a delayed implant approach in order to get predictable results. But nowadays, we know much more about biology, and we understand how everything heals and how to place an implant much better with a very predictable result. And the lecture is about this, going from class 1 to class 3, but without reducing the predictability of the results. But of course, taking advantage of the time, reducing the morbidity, the number of appointments, and also preserving the vascularization, going for a minimally invasive procedure. This is a huge advantage regarding not only the patient, but also ourselves.
Well, thank you very much for that fantastic introduction. Now could you maybe give us your protocol and, of course, workflow for this kind of specific intervention?
Yeah, the workflow has been changing constantly because during I've been doing this kind of approach for around 10 years in class 3 before I used membranes and bone chips, the biomaterials. Afterwards, I preferred using bone from the tuberosity. That's the clinical case I'm gonna share with you. But during the last years, during the last decade, I changed the workflow also because the dentistry has become another issue with the digital world. Now we have new technologies, new materials we didn't have 10 years ago. And so now it's easier for us to print a surgical guide to mill a provisional restoration in only 20 minutes. We can precisely place the implant prosthodontically driven and in a quicker way. So everything has been constantly changing. And I want to share with you what we are doing right now. And I will share with you the step-by-step technique from the scratch, from day one to the last minute when the final prosthesis is placed, is delivered.
Fantastic. Well, take it away.
Yeah, thank you. Okay, so do we start with the lecture?
Please do.
Yeah. Okay. So I first of all, I don't want to do things very complicated because we don't have much time. So my lecture will be focused on those cases without cortical bone plate, with a gingival recession, but the proximal bone is going to be preserved. Because if you have cases without proximal bone, sometimes you need many other techniques, for example, orthostructure, in order to reposition the proximal bone. I want to be honest with you, I don't want to complicate things too much. And first of all, as I said before, I want to share with you, with all of you, what is my protocol, my workflow nowadays with a socket where the bone is preserved, because the only thing I'm gonna do is to adapt this workflow to a class 3 socket afterwards with bone and with hard and soft tissue reconstruction, of course. So first thing I want to share with you is this slide. The first thing first, case selection is very important. Afterwards, I will go for digital planning. And this is quite easy right now with intraoral scanners, and everyone, or most of the people have CBCT at the office, so workflow becomes easier and easier every single day. I will try to preserve the bone on the back and side, not to damage the bone, not to raise a flap, using tunneling techniques, using minimally invasive surgeries. And I will do the socket preservation at the same time I place the implant simultaneously. The tissue reconstruction is done then at that moment, but I have to register the 3D position of the implant in order to print or in order to mill the temporary restoration. After 2-3 months of healing, I deliver the final restoration, the final zirconia crown. So we can apply immediate implants in the posterior area, not only in the anterior area, but in order to summarize, you know that in the posterior area, most of the times we don't use any loading. We customize the healing abutment. We customize the healing abutment because we don't have the aesthetic demand by the patient. But in the anterior area, we can have two different situations. One is the optimal situation. I'm able to place the implant with a high torque, with a good primary stability. The second one is maybe you don't get a very high primary stability because of many different reasons. You are not very experienced. Maybe the shape of the anatomy, the shape of the implant is not the best one. Is not the threads are not very aggressive, whatever. In those cases, we customized the healing abutment with composite, or you can mill it, whatever. There are different kits in the market in order to do this also, in order to stabilize the blood clot. But of course, we don't want to load the implant immediately because there is a high risk if the primary stability is low. So talking about those optimal situations, where I was able to place the implant with a high torque. Then everything changes depending on the situation of the cortical bone plate. Maybe I have the best situation, the green one. The cortical bone plate is intact, and I also have a good quantity and quality of gingiva. Maybe the situation is not so good. I have gingiva, but no bone anymore. In some cases, in some challenging cases, the situation is even worse. The bone is lost, but also the gingiva is lost. I have a gingival recession. Those are called the class 3 sockets. Mm. So first of all, very quickly, I will go throughout the easiest case, the class 1 socket, but with a digital workflow. But if you pay attention to this patient, it is not so easy because you face some risks. This is a very young patient. First of all, the patient is very young and very, very, very picky. She is very demanding. She comes to the office saying, I came here because I want a perfect result. And she wants the perfect papillae, but also she wants a perfect color. And the color of this patient, the color of the tooth, of the central incisor is not so easy to replicate. It's a kind of white grayish color. It's not so easy for the technician to replicate this. And the papilla shape, those papillae are very, very long. So we have to preserve the tissue all around the emergence profile of the future crown. And so, summarizing, we cannot make a single mistake because this patient also has a gummy smile. She's gonna show, if we fail, she's gonna show the failure. And so her husband is not going to be very happy. Her mother is not going to be very happy. Nobody is gonna be very happy. And of course, I will be having nightmares. Okay, so first thing I have to do is to check out where the bone is located with a dental probe, the quantity and quality of the bone, and the quantity of quality and quality of the gingiva. And the gingiva, I look at it or I take pictures. But for the bone, I use radiographs on CBCT, as you know very well. So first thing first, I need enough bone on the apical area of the root in order to be able to stabilize the implant properly to end up with a high primary stability. And so first thing first, I have to observe how much bone do I have on the apical part of the root. At least should be nice to have at least 5 millimeters of bone left. But you usually have that quantity of bone. And of course, the width of the crest is also important. And with this CBCT and radiograph, I'm able to select an implant, the right diameter of the implant, not very wide, as you know, because I want to leave a couple of millimeters of space between the implant body and the facial side of the bone, at least. And the question is, what do I do right now? I fill up the gap with bone chips, or I use only a connective tissue graft, or I use both. And of course, it depends on the biotype, the phenotype of the patient, how thick the bone is, how thick the gingiva is, what is the condition. I import everything into the software. I don't mind good software, which kind of software you are using is like driving a car, you know, more or less you are doing the same thing with every single software. The CBCT and the STL files coming from the intraoral scanner are overlapped there. So I'm able to plan everything digitally. And with that, I place the implant digitally in the right position, prosthodontically driven position. As a result, I obtain a final STL file, the final STL file, which I'm gonna use to print the surgical guide. Why do I use a surgical guide for a single implant if I have plenty of bone? Because I'm gonna place the implant perfectly without thinking, and I'm saving a lot of time. And because nowadays to print this surgical guide costs me around $1. Doesn't make sense not to take advantage of these new technologies we have right now.
But surely the issue isn't the fact the cost of the actual surgical guide, it's the cost of the equipment that is needed to be put into place in which to be able to use that.
Absolutely, you're right.
I mean,
You're
having all
right.
this equipment, I'm getting the impression as well. It gives confidence to the person, to the dentist as well.
Yeah, and I think that, but I think that every day the equipment costs less, like a mobile phone. You remember that if you compare the capacity of the first mobile phone years ago with a mobile phone from now, the mobile phones we have right now are more powerful than the first computer I had. They are amazing, and they are cheaper. They are becoming cheaper if you take into account the how much power they have. The same with this, and you have to remember that every dentist nowadays, most of the dentists have an intraoral scanner that which is used for many other things. So now the equipment, you already have the equipment there. You already have the CBCT. Most of the offices have the equipment there. So it's not so expensive. It was more expensive years ago. And that's the reason I mentioned that, because I remember a surgical guide when I started with this. Surgical guide for a single tooth was around around $500. Compared with this, is quite different. But you're right. And the main advantage of doing this kind of using this kind of workflow is that I'm seated, relaxed in front of my computer, and I'm able to place the implant in the proper position to move around the implant in order to obtain the right emergence profile of the future restoration, because the precision is so high when the surgical guide is dental supported that I'm gonna go to the surgery very, very relaxed. Remember that I will try to avoid raising a flap. So it's like the disadvantage of these minimal invasive surgeries is that you don't see so much, you don't see very well the bone, because you are working with tunneling techniques. So I think it makes sense. So we print the surgical guide. We can print several surgical guides at the same time, and the precision is very high, very, very high. The drill is guided by the shaft. The shaft of the drill is the same. It changes only the active part of the drill, you know? So let's go for the surgery. Let's extract the tooth with a minimal invasive device, you know, in order to trying to avoid any damage on the buccal side, on the buccal bone. And you have in the market this kind of devices, X-Track or Binix. These are screws placed into the root in order to pull out the tooth easily. And this is the day of the surgery. I check out once again where the bone is located. I removed the crown because the tooth was fractured. You could see this in the CBCT, and I used this kind of device in this clinical case. I used the X-Track to pull out the root, as you can see in this slide. So the root is out of the mouth very easily, and now it takes only 1 minute to prepare the implant bed. 1 minute, it's done very, very, very quickly. And new implant designs, as you can see here, this is a can-lock implant, are more or less in every brand. You have this kind of bullet designs with aggressive threads in order to be able to place the implant with a higher torque, with a good primary stability. More or less every implant brand has this kind of design. So it's easier for us nowadays than 20 years before to place the implant with a high torque. You can see that the implant was placed digitally driven with a surgical guide, and now the only thing I have to check out is that the distance from the implant, the neck to the gingival margin, in order to be sure that everything worked properly. Of course, in the end, you can make mistakes during the design, or maybe the surgical guide doesn't fit properly. So it's important to check out every single step. But I don't usually have many problems. So now I need a temporary restoration, but I'm gonna take the digital impression right now with the implant, with the scan body right now, because Tanya is gonna design the implant. This is a teamwork, of course. We are working as a team. Tanya is gonna design the temporary restoration, and meanwhile, Tanya designs the temporary restoration. I'm gonna go for the bone chips and the soft tissue management and the soft tissue graft. So I screw. Look at the picture, how clean the surgery is. I don't have any big flap. I screw the scan body onto the implant head, and it takes me only 5 seconds to register. I have to delete only that area with the finger, and I register once again the position, the 3D position of the implant. Now I go into the computer, and into the computer, I copycat the adjacent tooth, the contralateral tooth, and I design the emergence profile properly. It's important to end up with a concave shape, because mainly on the buccal side, because this concave shape of the temporary restoration is gonna hold the CTG. I don't want to push the CTG upward. I want the CTG to be there at the level of the gingival margin in order to boost the thickness of the gingival margin. I've been publishing about this, but in this short lecture, I don't want to explain too much about this, because my goal here is not to speak about the emergence profile, not so much. And so this kind of concavity is gonna hold the CTG, as I said before, and I'm able to shape this with the mouse very easily. In 5 minutes, this is done in the computer. You can use Exocad as I'm using here, or you can use any other software. It doesn't really matter. You can, with many softwares, you are able to do this. But what is important is to keep the idea that I need the space for the CTG to boost the thickness of the. You can see the concavity on the back side of the provisional. Of course, this concavity is going to be changed. It will be changed with the zirconia, with the final restoration, and this is only for the CTG. But after the healing, the CTG syncrease is around 30-40%. So afterwards, I'm able to change the emergence profile of the final restoration. So meanwhile, meanwhile, Tanya is working, my technician is working. While my technician is working, I go for the tunneling technique. I use a micro instrument, and I have to overcome the mucogingival line in order to release the tissues. And I use a tiny CTG harvested from the palate or the tuberosity. You don't need a huge CTG. It's only in order to thicken the gingiva, to avoid this kind of the depression concavity we have years later because of the collapse of the bone, because of the bone resorption happens when I take out the tooth, the periodontal ligament is lost. And of course, between the implant, the CTG is placed between the bone and the flap. The bone chips are introduced into the gap between the cortical bone plate and the implant body. And if you look at the pictures with a couple of sutures, everything is stabilized. The CTG is stabilized, and the bone chips are filling the gap between the implant body and the cortical bone plate, because the cortical bone plate in this clinical case was very thin. If the cortical bone plate in this case were thick, I wouldn't need the bone chips. Okay, but I would use the CTG. In other words, I prefer the CTG on the buccal side than to fill up the gap with the bone chip. And finally, when I'm finishing, the temporary restoration is coming up, and I screw the temporary restoration onto the implant head, and this is the final result. I didn't do anything at all. I've shined only the temporary restoration. I didn't dye it. You can dye it. You can end up with a more beautiful one, but I don't really need it, because I will go for it later on with the final zirconia rehabilitation. So this is before and after. This clinical case is simple. but with higher risks because the patient is very demanding and we have a gummy smile. You can see here. So we cannot afford any failure. And what do I do right now after 2-3 months? This is a very long implant, only 2 months. I'm able to change the emergence profile. And the final shape of the emergence profile depends a lot on the 3D position of the implant. That's the reason I'm so picky about the implant position. I want to position the implant in the best possible way before digitally and later on with my surgical guide. Because if I make a single mistake, for example, the implant head is too shallow, look at the emergence profile.
Actually, that was just coming off that was actually Victor Shahi has just asked a question with regards to that.
Yeah.
In case the implant is not placed ideally, of course, which prosthetic variations, abutments and restorations must be made? So just as I say, coming off what you're just currently mentioning.
Yeah, that's that's a good question. If I make a mistake, sometimes I can't solve it, but many times it costs me money because I have to use another abutment, maybe a metal abutment, made a metal framework in order to be able to compensate the bad position of the implant head. I cannot use zirconia because if the implant is not perfectly placed, the zirconia wall of the crown is going to be too thin on one side, too thick on the other. Right. The risk of fracture is very high. So I have to use the milled abutments, and this is more costly. And sometimes I have to cement a crown onto them. But I don't want to do that. Yeah. Of course, I can use also for those who are listening. I can use also angulated screws. Screws with angulated channels. Problem is that those abutments are wider. If you have a very wide tooth, okay, you can go for it. But imagine we are substituting a lateral incisor. It's too wide, the abutment. So those are details we have to consider. Of course, this is, as I said before, a short lecture, and I don't want to spend too much time speaking about these tiny details. But I have very good reasons to do this in that way.
Okay. Well, thank you, Victor, for your question. So yeah, let's move on.
So with the final restoration, I'm able to change the concavity. The initial concavity of the final restoration. I don't need that aggressive concavity. It can be smoother. And this is the final zirconia crown. I changed the emergence profile, and I went from here to there. Okay, you can see that. Look at this. This is very interesting. On the left, you have the emergence profile of the temporary restoration after removing the temporary restoration. On the right, you have the emergence profile after removing the zirconia crown. I removed the zirconia crown only in order to take a picture, in order you to understand how the emergence profile has been changed slightly. Okay, I went to the left, from the left to the right, without changing the emergence profile, adding composite or using a second temporary restoration, because I want to be more efficient. I can afford doing this because my gingiva right now is thick. So if I have a good gingiva, the gingiva is able to adapt easily to the new emergence profile, and because the change is a tiny one, so I'm saving time. Because I've done only 2 appointments. First one with surgery, implant, extraction, implant placement, temporary implant loading. Second appointment was in order to deliver the final restoration. But I didn't reshape the emergence profile with using composite as I was taught many years ago. And this is the final restoration. And look at the height of the papilla. They were preserved. And the clinical case is not easy. And this is a movie in order to check out the result.
Fantastic.
And it was done in only 2 appointments. And I've been doing this for many, many years. I published some papers in 2006, but they have a 22 years experience with a CTG on the back side of the implant. Before we needed 3 appointments in most of our cases. Sometimes we need more, of course. Maybe you are thinking about and the case where the color is very difficult, or the shape or the texture. Of course, sometimes I need more appointment, but you have to agree with me that in most of your cases, the most frequent extracted tooth in the anterior area is the first premolar, and the color is quite easy. In most of your cases, in 85% of your cases, you are able to finalize very quickly because they are not central incisors. So, but now we are able to do it in only 2 appointments. The first one is in order to speak with the patient, to take a CBCT, digital impression. The first one is for surgery, all of it done at the same time with the implant loading, with the temporary restoration, the liver, and the final one is for the final restoration, the delivering of the final restoration. And this is a huge advantage. And we can afford to do this because nowadays we are working in a different way with a digital workflow. So, but not every single case is like this. Sometimes I have a gingival recession. Other times I already have plenty of soft tissue. So if I have gingival recession, sometimes the CTG is gonna be partially exposed. If I have overcorrection, if I have plenty of soft tissue, thick gingiva, I don't need a CTG. So I don't want to send the message that in every single case I do the same. Because in some cases, I don't need a CTG, of course. But I wanted to share with you at least a tougher case, a more complicated case. Sorry, I don't know what happened. And yeah, and so sorry. And of course, the condition of the cortical bone plate is different depending on periodontal or restorative problems the patient was having. Sometimes the cortical bone plate is completely gone. And in those cases, we were told, of course, you know very well, that it's much better to use membranes or socket preservation techniques. But there are papers where they compare the use of membranes without membranes in socket preservation, and they don't really see a big difference. And also, we know for sure, because it's being widely published, that we are not able to preserve 100% of the volume, of the socket volume. No way. It doesn't matter what you do. It doesn't matter what you do. This is not possible. So question is, hey, Ramon, where do you use socket preservation technique? I use socket preservation techniques when in Pontic sites. But when I'm placing the implant, I go for the socket preservation at the same time I place the implant simultaneously. Okay, so in these cases, for example, on 21, I'm using socket preservation because this is a different case. This is a Pontic site. Another case, another example. In this clinical case, I don't have cortical bone plate on the back side of the lateral incisor, but I'm not going to place an implant. I'm going to go for the socket preservation technique. I deliver the temporary restoration immediately, but this is a Pontic site, okay? I don't need an implant here. What did I do many years ago? Ramon, what did you do in these cases, in those cases, challenging cases without much bone on the back side many years ago? I placed the implant. At the same time, I went for the socket preservation, and I covered completely the implant with a CTG at the same time. In order to hold the papilla volume, in order to boost the gingiva. Problem with this, of course, it is predictable, it works nicely, but it takes too much time. Why? Because this is the workflow. You can see here that I have a gingival recession. The biotype, the gingiva is thin on the back side of the tooth to be removed. Not only that, you don't have any contact point. I have a diastema on the mesial and distal part. I place the implant. I place the healing cap. I fill it with biomaterial, the gap between the cortical bone plate and the implant body, and I use a CTG in order to cover it all.
What is the size of the CTG that you put inside? And how deep does it go? Sorry, I'm just cutting in there because it's a question from one of people watching live today.
I wanted to keep it simple, but you already seen that this is a huge CTG.
I
know. You realize that this is the morbidity of this procedure is higher. It's not anymore a tiny CTG. This is a 20 millimeter. At least you need 50 millimeter CTG. So it's wide and very, very large. So of course the morbidity is higher, but the main disadvantage is that you have to start all over again to rebuild the emergence profile. You have to expose the implant and to shape the emergence profile. You've lost, you don't have any emergence profile anymore. So it takes a lot of time to go from here to there, with the temporary restoration. But it works, of course it works. And I was able to preserve the papilla height 9 years later. I think this is the picture taken 9 years later, but the case was done 16 years ago, more or less. I cannot remember exactly. So the problem with this is that, in my opinion, morbidity is higher, as you were asking me, but it takes too much time. It's not too efficient. It takes too much time, in my opinion. So imagine this another clinical case. In order to show you my point of view, Class 2 defect without bone, you can see the dental probe, the periodontal probe on the right side of your screen. I have a 10 millimeter, almost 10 millimeter defect, 9 millimeter defect, but also on the palatal side because of fracture. So I want to save time. So now I don't want to completely cover the implant. So another possibility is to cover the implant only partially. Once again, observe this. I'm talking about big, very large CTGs. So for many dentists, this is not easy to harvest this CTG. And in some palates, is really complicated because some palates are really thin. So at that time, many years ago, many of us were using membranes. So I was using a membrane. This is more costly because you need the biomaterial, the membrane, and the CTG was between the membrane and the flap on the back side in order to boost the gingiva. And everything was sutured, but the healing gap was exposed, as you can see here. And the CTG was stabilizing the wound and the blood clot. Okay, I professionalized this using those crowns onto the stump, cemented onto the stump. Once again, I share with you that this is working. And this is before, and on the right, you can see afterwards. And the implant was wider at that time. But once again, what is the disadvantage? You can see that I have to change. I need a professional to shape the emergence profile, and I will work with the composite shaping the right emergence profile, shaping, holding the papilla, modifying the proximal side of the provisional, the back side. Sometimes I need 1, 2, 3 appointments. It's tiresome. In my opinion, this is tiresome. I don't want to do this anymore because I have hundreds of patients like this. I don't want to spend appointments on appointments. But of course, I agree with you. It works. In the end, I get the final emergence profile, as I told you before. But look at the picture. Initial temporary restoration. The papilla shape is gone because you didn't have they are a provisional restoration. So you need time, appointments, but also to wait in order to the papilla to feed the embrasures. And in the end, it works. And this is the final result, the pictures before and after. But it took me too much time. And this is what I try to avoid. 7 years later, but too much time. And look at the emergence profile of the final restoration. It's too convex. Why? Because I had to push the tissues proximally, because I was not able to hold the papillae. And this is disconnecting and reconnecting of the provisional sometimes provokes bone remodeling, as you know very well. So this is working. It is predictable, but it takes too much time, and the morbidity is higher because the CTG is larger. So now, colleagues, dear colleagues, we reach this level. Now we are working. This is a recent case done 3 years ago, more or less. So now I'm getting older, so I don't want to work anymore so much, you know. So I've been working for more than 20 years. I prefer to keep it easy. So, but this is a tough case. Bone is completely gone on the back side of the tooth, but not only that, they have a gingival recession. So if I follow the workflows I was taught many years ago when I was younger, I would extract this tooth, and I will wait for 8 weeks. Afterwards, I need a membrane, bone regeneration to raise a flap. After 6 months, I will place the implant. Maybe after 1 year, several appointments, I will have a provisional, which is necessary to modify in order to end up with the right emergence profile, as I showed you right now. But I don't want to do that. And that is very, very costly for the patient. It costs a lot of money. And maybe you face many possible complications. On the other hand, pay attention to the distal part of the distal papilla. This is a periodontal patient. As soon as I remove the tooth, everything is gonna collapse. And your papilla there, your distal papilla is gonna disappear because you don't have bone holding that papilla. So if you apply that technique, for sure, maybe you will end up with that very open embrasure on the distal part of the crown. So I will choose a different approach. Exactly the same approach I'm using in class 1 socket, but now I have to reconstruct the hard tissue, the bone, the soft tissues, of course, immediately. So I place the implant till now very easily. I use a scan body in order to register the 3D position of the implant. The sequence is this: case selection, digital planning, minimal invasive extraction, digital impression, guided placement, socket preservation, TTG, provisional, and material selection, and final redesign of the emergence profile of the zirconia crown. But the question is, how do we preserve the socket? How do I reconstruct? I prefer to speak here about the socket reconstruction. So sorry,
just to get a rough idea, when you put timing, what kind of time are you actually kind of identifying here? Give us a rough time plan that you kind of you put this into.
From the beginning to the end.
Right.
I'm able to finalize a case like this in only 3 months. But this is, first of all, this is a priest. So God was on my side, and this is not a joke. This is a priest. So
and God was on your side.
Yeah. So maybe God was on my side, but the priests are really busy nowadays. And I finalized it. I substituted the temporary restoration after 1 year because he didn't come before. I cannot remember if it was because of the pandemic. Right now, it was around 2020. You know, but you will see that it's quite a straightforward protocol. I will show you. Let me show you this. I extracted two. I'm checking out that I don't have any bone on the back side. You can see this on the right side of the screen. And till now, I didn't change anything comparing this step with class 1 socket. I'm doing the same thing. It's my surgical guide, implant placement, and look at this. I want you to pay attention to this. Look at the treatment planning, and look at the final implant position. On purpose, I'm using a very long implant because, of course, I want a high torque. I want to load the implant immediately because one of the most important function of my temporary restoration is to stabilize the graft and the blood clot. I want to use a temporary restoration. That's the reason. If not, there is no reason to use a very long implant. So I registered the implant position, as I said before, and we have plenty of literature supporting the predictability of immediate loading nowadays, but not in single implants. In single implants and class 3 sockets, we are advised not to place the implant simultaneously to the socket reconstruction. Actually, you have plenty of papers. And so only in class 2 sockets, they recommend socket preservation without implant placement. So class 3 socket is something that more challenging, and it is not recommended to place implants simultaneously to the hard and soft tissue reconstruction. Of course, you need experience. Of course, you need experience in order to do this, but you need experience for everything, ortho, endo, not only for this, before doing the procedure. We published some kind of technique with my friend Sofia, but the technique I'm using right now is not the same published with him, and it is inspired on the technique published by Dr. Da Rosa in 2013. So we have case reports, we have publications, not many, but we have publications. This is not something experimental. The technique I'm using is a little bit different. You can see a clinical case where done many years ago where I'm harvesting hard and soft tissue at the same time, like a tiny bone block with its soft tissue, and it's introduced there without any suture, and it's harvested from the tuberosity in this way. That Rosa usually raises a flap. When I can avoid raising a flap, with chisels, I'm able to harvest hard and soft tissue from the tuberosity, and in that way, I preserve the cortical bone plates. If I need more bone in 5 years for another tooth into that mouth, I'm able to harvest once again the same quantity of bone from there, because this becomes a defect which is auto-regenerated by itself. So this is more or less the summary of the technique with this kind of pictures by Dr. Francois Vigouros. It's a nice friend I made in Belgium last year while lecturing about this topic. So coming back to our patient with a blade in order to cut the gingiva and chisels, I was able to harvest a bone block with the gingiva. You can look at the CBCT images in order to understand my point of view. Before, after harvesting the bone, and 1 year follow-up, you can see that I still have plenty of bone. The tuberosity is not destroyed because I harvested a bone block from there. So this is my graft harvested from the tuberosity, made of bone and soft tissue. You can see here on the other side soft tissue, and it's introduced on buccal side of the implant, and almost completely covered throughout the coronal reposition of the flap. even without raising a flap, without the vertical releasing incisions, I'm able to release the tension, to cut the periosteum in order to release the tension of the mucosa and to reposition coronally the soft tissues. I'm using this kind of sutures held there with composite on the facial side of the adjacent teeth. Of course, the soft tissue is de-epithelialized, and you can see that the soft tissue is covering the bone, the harvested bone, which is packed there. No screw is used in order to stabilize it, because this bone harvested from the tuberosity is a soft one. And this is before and after the healing. The implant was loaded immediately, of course. And this is before and after the healing. And look at this. After waiting for many months, I did nothing. I didn't remove one single time the temporary restoration. The gingiva is much better, is better adapted to the emergence profile of the temporary restoration. Look at this. After the surgery, 3 weeks later, look at the situation right now before removing the sutures. After 3 months, 1 year later. Look how beautiful the tissues are right now, and the size of the embrasure. The tissues are feeling much better, the embrasures. And I'm being efficient. The morbidity is being low, very low for the patient. It's been done in one single appointment. This is a costly, effective treatment. And from my point of view, I think this is predictable, but because I didn't change many things from my old protocol. When I remove the provisional, do not forget about this. The biological advantage of the temporary restoration. The temporary restoration is stabilizing, it's helping me to stabilize the gum, the blood clot. I didn't raise any flaps, so I don't have scars. I avoiding possible complications, and I'm keeping the volume of the soft tissues. I went from here to there. And now the only thing you have to do is to rescan the shape of the gingiva and to change the emergence profile of the final of the zirconia restoration. You deliver the zirconia restoration and you end up like this. And we went from here to there in 2 appointments. But the second appointment lasted 5 minutes. Everything was done in one single appointment. And this is before and after. A complicated, very complicated case, because the distal papilla was very compromised. Not because the gingival resection. I'm not worried about the gingival resection. Look at the condition. Let's use these lines in order to compare before and after, the result before and after. In a couple of appointments, I would love to be treated like this if I were the patient. And this is the planning after the surgery and the final situation. I have plenty of bone. There is an artifact because the patient moved a little bit, but this is not a bone defect. You see that you have bone on the back side. This is the result, different lines. So let's look at the pictures.
You mentioned how cost-effective and time-effective it is, but what about the swelling post-operation and of course the pain during the procedure?
No painkillers are used. Why? Because I don't raise the flap. Okay. I say to the patient, you can use a painkiller that day if you want to. You will feel a little bit uncomfortable, but you don't have to feel pain. Actually, I say to them, if you feel any pain, to call me, because this is wrong. You don't have to feel any pain. And of course, swelling, you don't face any swelling. It's almost nothing because the minimally invasive approach. If I raise a flap, I need more stronger anti-inflammatories, But with this, everything becomes easier. That's the great advantage. Good question. So with the pictures, you look at what I did, in order to preserve the volume of the tissues. And this is the evolution, 3 weeks, 3 months, 1 year, and 2 years. And you can see that but think about this. Imagine you have 1 year, 100 patients like this. And instead of a couple of appointments, you go for the socket preservation, GBR procedure, you wait for 6 months, you place the implant, you cover it all, and once again, you expose the implant and you reshape the emergence profile. So you've been doing maybe 10 appointments in order to deliver a crown, 10 appointments in 100 patients. So one with 2 appointments is 200 appointments. So I have more free time. Not at all because I have to lecture, but anyway. Okay.
And this is the follow-up.
Look at the quality of the soft tissues. How much did it take the second appointment? 5 minutes. So my take-home messages are: plan the case carefully. Use the new technologies because you have many advantages, and the implant position is paramount. If you want to use zirconia crowns to save time and complication and avoid complications. Guided surgery is pretty predictable and efficient when the surgical guide is dental supported. Minimally invasive procedures are done in medicine. Everything has changed during the last century amazingly. During the last 2 decades, laparoscopy was not used 50 years ago. Now many doctors, this is not about dentistry, it's about surgery, this is about biology. So avoid raising flaps if you can. Of course, there are cases where I need to raise flaps. Hard and soft tissue reconstruction is predictable at the time of implant placement. We have plenty of papers talking about it. And we have the possibility to deliver immediately the temporary restoration. And the main advantage is not the function, it's not the aesthetic. For me, it's the biological one. The stability of the blood clot, the stability of the wound, the stability of the graft, if necessary. So socket reconstruction in cases with a low primary stability and large tissue deficiency, of course, is always an option. And sometimes I don't get the right primary stability. You need to have many different workflows, but in many cases, you can go for it. You can load the implant.
You can do it.
Thank you so much. Thank you, Hayley. Thank you, Alberto. Thank you. Every single guy from all over the world who is looking at us right now for the effort for being there. It's been a pleasure to share this time with you. And if you have any question, if I'm able to answer,
we have a lot, Ramón. Don't go anywhere. I have a question before I get started on them. Why would any professional be reticent as to employing this technique? What areas may they not have enough experience or confidence in that may kind of prohibit them from really kind of taking that step and maybe trying it?
Yeah, well, I think of course, I'm sure that every single doctor looking at us, listening to us right now, knows that you need to know about implant placement, perio, and prostho in order to get predictable results with this technique. Because when we are talking about the immediate implants, we need to know about different issues. Of course, sometimes if your colleague is next to you, maybe you are the periodontist and the prosthodontist is in front of you, and you don't need to know about everything. but you need a very good communication between the members of the team, the prosthodontist, the periodontist, and the technician, of course.
So that is, of course, paramount. Do you maybe think, maybe some lacking experience in harvesting or maybe an issue as well?
Yeah. You need experience in mucogingival surgery in order to do this for sure, and a long experience. I have to be honest with that. You need a long experience in CTG harvesting from the palate, from the tuberosity. Is not enough. You cannot do this if you are only an oral surgeon placing implants. This is another level. You cannot do that. But I would say you cannot practice modern implant dentistry without mucogingival surgery nowadays, because in a young patient like you, do you imagine to place an implant after only 3-4 years? You will end up with a very large, very long crown with a depression on the buccal side, maybe showing the gray scala of the abutment. No patient allows you to do this nowadays. Implant dentistry being has gone from function to aesthetics nowadays. So it's like, but in every field, you can see this. For example, digital field, you can see that the qualification of the people is higher nowadays than before. So,
of course, and I think you're a prime example of someone who has embraced technological and digital evolution that is currently going on. Now, I'm going to now concentrate. We have a lot of questions because it's been a fantastic lecture.
To summarize, yeah.
And I may be going back to the class 1, class 2 cases that you mentioned prior to the last class 3 case. Could you please give guidelines for the ideal insertion depths of the implant, e.g. high scallop versus low scallop phenotype? I think that's very specific as to
it's not easy to do that, but because I try to summarize, but summarizing in high scalloped, in jagged patients, I prefer to place the implant a little bit deeper, around 4 millimeters, not 5. But in shallow, in low scalloped patients with gingival, older patients, those are older patients. The implants, I place the implants around 3 millimeters from the gingival margin. From the future gingival margin, you have to consider the future zenith of the crown.
Some people have connected slightly later on, so they may have missed some parts of your lecture. So Per Oscar Otterstad wants to know, do you use anatomically customized or prefabricated titanium bases or interface?
Yes, of course. I think we spoke slightly about that. When the implant is not very well placed, you have to use that, because you don't have enough space for the zirconia. In narrow spaces, for example, with narrow implants, sometimes you need that, or you need to place the implant precisely. But if you plan everything in advance, I promise you are going to save a lot of money, because even with narrow implants, I've been using sometimes shoulderless abutments coming from the implant brand, and those are much cheaper than using the milling ones. Yeah.
Thank you for that response. Arshad wants to know how many weeks after placements, you actually did respond to this. You did actually mention this. After placement, will you deliver the final crown? Also, do you do Ostel measurements? No,
not at all. I did it many years ago. You have papers talking about that. Torque is more predictable than Ostel. I don't need that. I use torque. You don't have to. I don't want to waste my time, but you can use it, of course.
Okay, Guillermo wants to know: do you recommend acellular collagen matrix as an option for rebuild the soft tissue?
So sorry, could you remember? Could you repeat?
Do you recommend acellular collagen matrix as an option for rebuilding the soft tissue?
You don't get a collagen matrix. Look, bone chips are substitute, can be a substitute of a bone graft, but collagen matrix being published, and you can read the last systematic reviews, are an alternative, but not a real substitute at the moment. I'm talking at the moment. What do I mean? I mean, you don't get so much tissue, and for sure, you don't have creeping attachment. So you cannot get this result with collagen matrices. I use collagen matrices for other things. I don't mean they don't work, but you can read the papers, okay? You don't get it. This is not a substitute.
Okay, now Maheshwara MV would like to know, on the slide where you temporary with TI base, you have labeled emergence profiles as A, B, and C. Could you kindly provide insight, a bit more insight as to the diagram that you showed?
Yeah, about the emergence profile. You mean? Yeah. I can send you over my paper. I wrote the paper. We didn't have much time. That's the reason I didn't explain it very well. We were summarizing. We want a very narrow emergence profile in contact with the implant neck in order to have space for the biological width to be reestablished without bone remodeling, without bone resorption. Okay, and we connect that area with the outline of the emergence profile. But the most critical part, in my opinion, is the part in contact with the implant neck.
Right. Our next question is, how do you harvest block in IDR technique from the inside of the tuberosity, preserving all walls? Is it hard to remove it without destroying the buccal plate?
Of course, this is a summary. This is a short lecture. I have videos showing that, and I'm using very sharp chisels, and I do the incision 2 millimeters away from the buccal and from the palatal, and through the incisions made with a blade, I go with my chisels throughout those incisions, and of course I have to keep the chisel 2 millimeters away from the sinus flap in order to avoid any communication, any oral antral communication. But you can measure with the help of the CBCT, that's the reason you need a CBCT, how much bone and soft tissue you have.
Okay, I think we have time for one more question. Any preferences to allograft or xeno or mixing while grafting class 3 sockets?
When I don't have the possibility to use the tuberosity because the tuberosity is too small, because this is my first choice, I prefer xenograft. Xenograft, for example, Mineros X, Mineros XP, or BIOS, for example, some examples, but any other can work nicely. I'm also using Purgo.
And well, thank you for that precision. Just one more question. Is ice cream cone membrane technique in the past then?
Absolutely, in my opinion. Sorry, but it takes too much effort, too much time. You have to use a membrane. You have to overcorrect. You have to reshape the emergence profile. I think that you can use it. Of course, you have many techniques in order to reconstruct the sockets, but it's gonna take a lot of time, and time is money. And you remember, the topic of this year is inflation.
Yeah, right.
Sorry for this.
And we're all
Sorry
concerned.
for this, but everybody is talking about the financial crisis. But do not worry too much. We've been through hundreds of financial crises. Every morning the sun rises.
Where can we find out more information? Is there anywhere that we can?
About this, I think there are courses all around the world, not only by me, but many other guys. Of course, about this topic, I give courses also my training center. I have 2 training centers in Spain, and also I will be in many countries. I would say too many countries this year, next year. So you can follow me in Instagram or wherever. You can write to me, and they will answer to you, because sometimes I'm constantly traveling and changing my places.
Thank you very much. Actually, you mentioned courses.
Thank you.
The EAO first certificate in implant dentistry is, of course, the only EAO online training, 23 hours of education within 6 months only, covering a range of topics, led by 18 world-renowned experts from 6 of the best European cities. It has already started on January 13th, but registrations are still available until the end of this month. For more information, check the description in just below. Unfortunately, run out of time for my very first Just Ask with in 2023, and what a fantastic guest to kick this year off with. Thank you so much for your fantastic lecture, for your time.
Thank you, Hayley, for being such an amazing host.
Thank you. And of course, answering everyone's questions. Please hit the subscribe button to stay updated with all of EAO videos. We'll be back for another Just Ask on Monday, the 6th of February. Thank you very much, and have a lovely morning, afternoon, or evening from wherever you're tuning in around the world. Thank you.
Thank you so much.